Thank you so much. I just want to start by saying what an honor it is for me to be here sharing my thoughts on this issue of safe supply. My name is Jeremy, Dr. Devine, and I'm a resident physician currently completing my training in psychiatry over at McMaster University. It's such a privilege to add my voice to that of Dr. Humphreys, Schellenberger, Dr. Lemke, just incredible leaders on this issue of drug policy and addiction, so it's a real honor for me to be here. The issue of safe supply is much more than an academic debate. Safe supply has growing momentum across Canada. The 2021 federal budget has allocated about $60 million specifically towards implementing 18 different safe supply projects across Canada. In the BC Ministry of Health and Addictions, they estimate that about 12,000 Canadians currently have access to a safe supply. And that number is likely larger if we consider other provinces. This is a really concerning development in Canadian drug policy. The increasing practice of safe supply is dangerous and I feel oppressive to the individual who struggles with homelessness and addiction. Really, safe supply is far from an evidence-based and thoughtful public health intervention. It's really rooted in what I feel is a misguided ideology that denies that drug use in the setting of addiction is intrinsically dangerous. I really feel that safe supply is best understood as kind of a radical form of harm reduction, which has pushed that philosophy far beyond its necessary limitations. Let's look at some of the claims made by safe supply advocates and the evidence which either supports those claims or refutes them. Safe supply advocates will argue that the provisioning of high doses of medical grade opioids to an individual who struggles with regular fentanyl use will help reduce their reliance on the street supply of fentanyl. They argue that the individual provided a safe supply will be at a lower risk of overdose death as their opioids are medically administered and thus considered safe. But for those who are even remotely familiar with the nature of addiction, this idea on the surface should be met with strong skepticism. A central feature of addiction is the inability to control one's use. And when one is addicted, gradual tolerance and escalation of use is inevitable. That a regular fentanyl user will have their opioid craving satisfied by being provided comparatively weaker hydromorphone or heroin is highly suspect, and I think wrong. Preliminary evidence on the effectiveness of safe supply interventions is extraordinarily scarce. But what does exist confirms what we would reasonably expect. The vast majority of those who are prescribed a safe supply continue to use fentanyl on the street. Dr. Mark Tyndall is a safe supply pioneer located out in British Columbia in Vancouver. Dr. Tyndall has enrolled a number of severely addicted fentanyl users onto an opioid dispensing machine. This machine distributes high doses of hydromorphone directly to the individual who struggles with the fentanyl addiction multiple times daily. Regrettably, in my opinion, these machines have proliferated across Canada. There's some in Nova Scotia, Ontario, and of course, British Columbia. In a 2020 podcast episode where Dr. Tyndall was interviewed, he shared the early results of his experiment enrolling severely addicted fentanyl users onto these vending machines. If I could just quote him directly as he discusses the preliminary results. Quote, "I put 15 people on the machine. We did follow-up urines on everybody, and 90% still have fentanyl in their urine. I think they're using the drugs that I gave them. For many, it's not enough. For some, they still want to buy something." These early observations by Tyndall should really call into question that basic claim made by safe supply providers, that providing high doses of opioids will allow them to abstain from being exposed to fentanyl and thus at risk of overdose. Two Canadian studies, the North American Opioid Medication Initiative, NIOMI, and the follow-up study to assess long-term opioid medication effectiveness, Salome, are frequently invoked by safe supply advocates as evidence for the alleged prescribed safety of heroin and hydromorphone in the setting of severe addiction. But this is incorrect. NIOMI and Salome do not meaningfully inform the practice of safe supply. These two studies were conducted in British Columbia, and they simply examined the effects of giving high doses of heroin and hydromorphone directly to someone who struggles with a heroin addiction. At the time, they found that those who were provided heroin and hydromorphone seemed to use less street substances overall, although are still using quite a fair amount, and seemed to have decreased healthcare costs associated with that. The practice of giving heroin and hydromorphone did seem to increase what they somewhat disingenuously call treatment retention. This unsurprising finding that when an individual is given high doses of heroin and who has a heroin addiction, they're more likely to return to the clinic, treatment retention. Furthermore, these studies gave heroin and hydromorphone under extremely restricted conditions. Individuals were given it multiple times daily, and they had to be monitored after being given heroin or hydromorphone. This is a stark contrast to safe supply in Canada as it's being practiced, which features the relatively free distribution of opioids. And furthermore, both of these studies were conducted sort of in the 2005, 2008, during a time when fentanyl was relatively absent from the drug supply. And it's not at all clear to me that the results still hold now that our environment is so contaminated with fentanyl. So really, to summarize, Naomi and Salome, I think you might hear more about those. They can't be credibly invoked as evidence that support this practice of safe supply. Finally, some of these earlier studies, which on the surface appear to support the practice of safe supply, are clearly conducted in a biased manner towards their favored ideology. With these more recent studies that I've looked at, it's clear to me that the benefit of a safe supply is a foregone conclusion for these individuals. And that's all that's left is to sort of rearrange the results in a way that maximizes the political success of the safe supply project. As an example of this, I want to draw the committee's attention to a recent report that was published just in January of this year, January 2022. This report was published by the London Intercommunity Health Centre, and the report title was Safer Opioid Supply Program. It was conducted out in London, Ontario. The chief lead is Dr. Andrea Sarita. She's another safe supply pioneer here in Canada. This report looked at about 250 patients who they followed for about a year's time. These patients were all provided a safe supply. They were provided very high doses of hydromorphone to be used as they please. As evidence of the success for the safe supply program, the report authors boast of a 94% treatment retention rate. Again, this unsurprising finding that when you're someone with a severe opioid addiction, you're much more likely to be retained in treatment if provided high doses of hydromorphone. But we should ask, what happened to those 6% of individuals who weren't retained in treatment? When you comb through the report, it gives no real indication other than that these individuals are, quote, no longer enrolled. That's about as much information as you get from the report. In fact, it was only during a webcast that was launched to talk about the report that Dr. Sarita, when asked directly, acknowledged that some of those 16 clients who were, quote, no longer enrolled, as said in the report, in fact died from a fentanyl overdose or died from infections related to injection drug use. Others were incarcerated or ended up in long-term care facilities. This is a problem because the report said nothing of that. They didn't mention it, and it presents a misleading sort of picture of the safety and efficacy of the safe supply program. I'm tempted to call it a kind of whitewashing of the data, which I think is deeply troubling. But these tactics are frequently successful. For instance, uncritical journalists at the CBC, they kind of see that report and they sort of accept the positive spin of it, kind of on the face of it. And they write articles which are supportive of safe supply. And I think in this way, this is kind of how the program has gained so much political momentum over recent years. And I see that as a big problem. Fundamentally, I want to argue that those who are struggling with addiction and homelessness deserve so much more than a supply of opioids. I feel strongly that safe supply undermines what should be the central focus of our drug policy, which is to free the drug user from the mental prison that is addiction. Safe supply undermines that. I feel strongly that recovery is within reach for everybody, but we need a strategy that fosters agency, self-esteem, and a sense of purpose for the drug user. As a physician, I don't feel that I can prescribe that as I can hydromorphone. It's a deeper problem that requires a deeper solution. I feel that in that goal of achieving recovery, we can look to some of the European countries, which are very progressive and have had a lot more success in managing this issue than we have in Canada. I'll mention briefly Portugal. It's the drug treatment system that I'm somewhat familiar with. In Portugal, drug treatment, the state will fund up to 3 years of inpatient rehabilitative care for those who really need it. And the state, once you're sort of released from rehab, will supply or will fund some of the salary for when you get back into the workforce. These sort of creative ways of helping someone maintain recovery, for which work is a vital element sometimes, I think go a really long way and are so much more powerful than a safe supply. I want to end my discussion just by quoting Dr. Goulart, who's one of the architects of the Portuguese healthcare system. He summarizes his philosophy just in these few words. Let me pull them up. He says, "Our first goal is to help people resume their dignity. That's the most important thing, to give them the self-esteem that they've lost." Thank you so much, committee, for listening to my thoughts on these issues. It's been a real privilege for me. I'm more than happy to answer any questions that the committee may have. Thank you.
Thank you, Doctor, for your presentation, and your obvious heart on this issue, so we appreciate that. First up, we have MLA Rosen.
Okay, I think we've got a bit of an echo. Okay, we're good. It's just the chair, not me. Well, thank you for your presentation. I see that you are a psychiatry resident with the Department of Psychiatry and Behavioral Neuroscience at McMaster University, and I think that's interesting for this discussion because one of the most prominent arguments I hear in favor of safe supply is that groups or individuals who support safe supply do still want addicts to get clean at some point, but many addicts aren't mentally ready yet, or they're not fit to take that step into recovery yet. And so safe supply is a good way to just kind of keep them where they are, keep them safe, reduce harm, because they're not mentally ready to take that step. So I would be curious to hear from your background in psychiatry what you would say to those claims, and from a psychological standpoint, what your opinion would be on such an assertion.
Excellent question. Thank you so much. If I could just speak from sort of personal experience from a recent patient encounter that I had on the ward just a couple of weeks ago. I'm going to keep it, of course, very vague, just respecting patient confidentiality. But I was asked to see a man who was admitted to hospital after a stroke. That was the consequences of injection drug use. This was a young man. He was in his 30s, and he had already somehow ended up being prescribed a safe supply. He was someone who struggled with homelessness. He was in and out of shelters at a motel, and he had ended up being prescribed a safe supply. And when I saw him on the ward, I found him in a moment of tearfulness. He told me that he was thinking about his drug use and how it's impacted his family, how he's been unable to really care for his mother, who had some health conditions. He felt really mixed about his drug use. And of course, I'm interested in safe supply, and I asked him a little bit about how he felt being on a program which distributes him high doses of hydromorphone and I feel enables addiction. And he said that he hated it. He wanted to be done with addiction. He wanted recovery. And in fact, this young man, he had, as I recall, about a year of sober time in his past, which tells me off the bat that, of course, this is something that he can achieve. He's done it in the past. And then I remember speaking with him, and I was hoping to direct him again in that direction. And I just think of the two options for him. On the one hand, we can ask him to re-enter rehab, to gain some self-esteem, to get some agency, to commit to sort of a better life. Or we could discharge him on a safe supply and feel that we've done our due diligence and that he's protected with his opioids. There's really a crossroad kind of moment for him. So I feel that maybe I've lost track of your initial question, but it's this idea of readiness, that safe supply is an alternative to recovery, which is, I think, wrong and undersells the potential of the person. Hope that helps.
Yeah, I just have one follow-up. Of the patients that you've dealt with, or of individuals you haven't dealt with but maybe have seen or spoken with, who have been prescribed safe supply, do you have any estimation how many of them were prescribed safe supply because they asserted that they were not ready to take the step to recovery versus how many were prescribed safe supply because the government decided for them they weren't ready to take that step?
Excellent question. And it gets to the thorny nature of sort of consent and what people truly want, and what someone wants in the moment of desperation and withdrawal might very well be a safe supply. In that moment, they might want that. But then as they have time to settle and reflect, is that really what they want for the rest of their life? It's this idea that sort of drug users are sort of rational actors and can freely choose what they want at the moment. I don't agree with that. And that's why I really wish, as a psychiatrist working in Canada, I really wish that we had a bit more of an assertive treatment regimen like that's out in Portugal, which directs people, even in tough moments, towards recovery. Portugal, for instance, I know you guys heard testimony from Mr. Schellenberger on this issue, but they have the Drug Dissuasion Committee, which assertively directs patients towards treatment. So I don't think that a lot of the time it's individuals freely choosing a safe supply. I think it's done out of desperation and just in the moment, and I don't think it really reflects their true interests.
MLA Fry.
Thank you.
Hello. Oh, I don't know if I'm working. There I am. Okay, good. So I really was struck by what you said about having a strategy that fosters agency. So in your opinion, as a physician, how do you find that agency and personal autonomy fits in when we're talking about safe supply? Advocates would say that, somebody is coming to the doctor to get this prescription, blah, blah, blah. But if the goal is freedom from addiction and the goal is recovery, how do you find that agency factors into the safe supply conversation?
I feel it completely erases it. I think that's the crux of it. I don't think that safe supply respects the agency of the individual. I think that some advocates will argue, well, we're empowering them. We're freeing them from reliance on the street supply, and that they'll be more free to make decisions in their life. But I just can't see the logic there. We have to remember that opioids have been historically classified as narcotics. And to be pedantic just for a second, narcotic comes from the word narcoon, which means to numb. Opioids numb the individual. They don't treat anything. They glaze over deeper issues and traumas and personal demons. And I just can't see what's healthy and progressive about that. So I feel strongly that safe supply undermines agency in the setting of addiction, which is the only true source of sort of self-determination and ultimately liberation from addiction, which I think people want deep down. Thank you.
Supplemental?
Yeah, and I guess it's kind of in a different vein, but in your position as a physician, I know part of the Hippocratic Oath is first do no harm. I certainly personally have an issue with when I hear of things like safe supply. I wonder how that even fits into a physician's Hippocratic Oath. And that's just and I'm not a physician at all. I'm a politician. So, I mean, maybe I don't know. Maybe there's something I'm missing. But I was wondering if you could expand on that. How do you think, how do you think that you are able to respect your oath and still practice safe supply?
Yeah, it's such an interesting question. I think intellectually with psychiatry, we've been criticized in the past, my field, as sort of offering medication solutions to deeper rooted human problems. And often I've been able to sort of push back against that for my work with thoughtful colleagues at McMaster who I think really do try to understand those issues and try to get someone better. But when it comes to the issue of safe supply, I have a hard time dispelling that idea that we are sort of just distributing high doses of opioids, not for the benefit of the patient, but maybe for the benefit of law enforcement, because the patient isn't using as much drugs on the street. They're not getting into as much trouble. Or maybe for the taxpayer, because some of these studies claim that safe supply results in less money to the taxpayer. As a physician, my sole goal is to empowering the individual towards health. I don't care about the taxpayer or about sort of if the police have a harder job. I have to think what's best interest of the patient. Safe supply complicates that because it asks us to consider prescribing something for vague health benefits vague societal benefits or healthcare costs. So that's sort of how I would think of that issue. Thank you.
MLA Amory.
Thank you very much, Chair, and thank you. Good morning, Dr. Devine, and thank you for your presentation here this morning. And certainly see your passion in the area, and it's incredibly encouraging to hear from those on the front lines. Now, I don't know if you watched any of these committee proceedings, but I have a particular interest in finding out as much about the possible successes and or failures of safe or open drug supplies in jurisdictions that have already implemented or tried these policies, especially here in Canada and perhaps even the US. Now, we've heard throughout our review terms like quote unquote safe supply, addiction maintenance, and so on. Are these terms used synonymously and or interchangeably? What proportion of patients, in your experience, who receive safe supply opioids then completely abstain from street-acquired opioids?
Right. So I should clarify that I've seen a generous handful so far of patients who are prescribed safe supply. And I'm always encountering them when they're in the emergency department or admitted to hospital for a complication of drug use. And yet they're enrolled on the safe supply program, which is theoretically supposed to ameliorate that or address it. So I would say off the bat that 100% of patients prescribed a safe supply continue, in my experience, which continue to use fentanyl to some degree on the street. And we heard that from that quote from Dr. Tyndall, who's enrolled patients on an opioid dispensing machine. 90% continue to use sort of fentanyl at a certain time point, and we don't even know down the road what percentage that number would be. And again, other data I've seen sort of out of London, 80% prescribe these doses, continue to use fentanyl. It just doesn't make, it's just the common sense suggests that individuals with a severe addiction, you're always chasing higher doses. It's not something that you can control. It's in the nature of addiction to want more and more and to seek that escape. So the very principle of safe supply is flawed, in my opinion. I think I missed the first part of your question, if you wanted to repeat that.
Yeah, very quickly, safe supply and addiction maintenance, are those terms used interchangeably and or synonymously?
Addiction maintenance and safe supply. You know, I think I would. You know, I don't really see how safe supply is differentiated from addiction maintenance. I think that a big criticism I have of it is that it enables drug use and perpetuates addiction. So I would call that, but I can't speak for others on that issue. Thank you.
Quick follow-up, if I can, Chair.
Go for it.
Thank you, Dr. Devine. We heard a lot of the presenters, including I think yourself, say that the primary objective and goal, and I think all members of this committee would confirm that as well, is addiction recovery. And I'm wondering if you can comment based on your observations and anything else that you might be able to offer to this committee, whether safe supply and addiction recovery can ever be reconciled. And to expand on that, have any subscribing quote-unquote safe supply jurisdictions in Canada and or the US made any meaningful progress towards addiction recovery statistics?
Towards addiction recovery statistics. Excellent question. I'll say that I don't see how we can reconcile the practice of safe supply with addiction recovery. I see them fundamentally as sort of opposing forces. And with respect to sort of addiction recovery statistics in Canada, you know, I've tried to research into that, and it's very challenging. I don't have great data on that, and I'd love, you know, if we could have a national effort to sort of figuring that out, because I think that it's probably higher than we think it is. Safe supply is fundamentally pessimistic. It tells the individual that they can't sort of grow and overcome addiction. And that they can't recover. So I think that we need to focus more on recovery.
Thank you. Next up, we have MLA Milliken.
Thank you, Chair. Thank you, Dr. Devine, for being here today. As was stated by my colleague, your passion definitely comes through in the presentation. I guess one of the reasons why our committee has been struck is because it is fair to say, I think it can be stated that there are definitely proponents of safe supply. And so I've talked to proponents, obviously, and one of the arguments or lines of logic that they use would be that when an individual is enrolled in safe supply, what it does is it offers an opportunity almost for an off-ramp. Every time there's a touch point between, say, a doctor who's prescribing and the receiver of the opioids, that could be an opportunity for the doctor to perhaps push the individual towards some of the proven treatments that people agree are proven and evidence-based. I guess my question would be, do you think that that's sort of bearing through on the data? Is that actually occurring? Or is it a situation perhaps where maybe there are negative externalities associated with safe supply that may end up being sort of more significant? Your thoughts?
Yeah, thanks for the question. That is a frequent line of argument. And I remember when I was a medical student, Toronto was getting its first supervised injection site. And my initial response was sort of, okay, this makes sense to me. Let's provide individuals a safe space to use so that we can make connections with them, as you said, and sort of point them in the right direction. But as I sort of looked a bit deeper into it and I saw some of the rhetoric and what I thought was the ideology out of British Columbia, where these ideas sort of first gained currency, I saw that was very much not the case. Many caring Canadians will support safe supply and harm reduction as a stepping stone towards recovery. But I have to be clear, that is not what's happening. That is not the direction that we're going in, and that's why I'm so concerned by safe supply. If I could just give a quick quote by Dr. Mark Tyndall. This is one of the safe supply pioneers who enrolls individuals on vending machines. Just to give you a thought of how he views recovery and what his thoughts are on that issue. He once said, quote, "One of our messages is to have reasonable expectations for people. So we've really pushed back on this, quote, everybody can recover type thing. People have these unrealistic expectations, like if we allow drug users to go to supervised injection sites, we need to get them hooked up with the care, and then we need to get them abstinent and recovered. That so rarely happens to people that I don't have those expectations anymore." So you see here this really alarming shift in how we're thinking of addiction, that it's something that can be maintained and perpetuated, and that the whole idea of recovery is somehow antiquated. We have to push back on that so far, and that's really what kind of drove me, I think, to put pen to paper and get my voice out there on the issue.
Supplemental?
Yeah, thank you, Chair. Sometimes I'll just ask the what I think is perhaps where the rubber hits the road with regards to the questions. And so I would say, in your estimation, is there a type of safe supply or addiction maintenance program that is in fact safe?
Yeah, so a good question again. I suppose I can see some of the rationale behind sort of maybe that those strict heroin injection programs or the strict hydromorphone injection programs. But again, this isn't safe supply. These are injectable opioid treatments, which places like the Dutch do, where patients are highly monitored, highly controlled, and it's really best understood as a palliative care approach to the drug user. There's a recognition that that individual is dying from their addiction, and there's not much that we can do about it. With respect to safe supply, no, I don't think that there's anything that can be safely done in that way. That's my personal feeling on it, and I think the data bears it out so far.
MLA Stefan.
Thank you. Appreciate your presentation. I appreciate your comment. We have an overdose prevention site in our community, and it is under what is termed a harm reduction pillar. I assume that safe supply would also fall under a harm reduction type of pillar. Mm-hmm. I was wondering what your knowledge is about the permanence of these pillars. Why is harm reduction elevated to a pillar that is similar in status as recovery in some of the political messaging that we're hearing?
Thank you. Having followed this issue closely, I think that there's something kind of chic about harm reduction. It has a certain radical element to it, a kind of progressiveness, and I think there's something really exciting. Many safe supply providers and harm reduction advocates will talk about dismantling kind of what they view as prohibition or the war on drugs. It has a kind of revolutionary, kind of extremist excitement about it, and I understand it to some extent. And I think that's why they've latched onto harm reduction and taken it to the extreme. I should say that Canada, regrettably, this is where harm reduction has gained the most momentum. Our drug policy has been completely dominated by harm reduction in the past probably 5 years, maybe even decade. We've put all of our resources into this novel philosophy, I think partly because of the excitement of it. And we've lost sight of the bigger picture. We've lost sight of the individual who's suffering with addiction and the imperative to move towards recovery. So I think that's where I place kind of the excitement around harm reduction. Thank you.
Supplemental member? Oh, you're muted.
I don't have any other questions. Thanks.
Thank you. Excellent. I don't see any other questions at this time. So with that, I would very much like to thank you for your time, Dr. Devine, and your presentation for us today.